We'll be breaking down all major concepts covered on the exam. Imagine a patient sitting in front of you in the emergency room, coughing up blood, their kidney function dropping by the hour. You don't have time to wait days for a biopsy result. You have to make a clinical call right now. Welcome to this special deep dive. I'm Harvey.
And I'm Donna. We are expert MCCQE reviewers, and well, our goal today is to help Canadian medical students tackle the exam review process with clarity and confidence.
Yeah, we are diving deep into the renal system today, specifically glomerular diseases. And for context, the insights we're unpacking are drawn directly from a stack of highly reliable StatPearls articles.
Right, covering a lot of ground.
Exactly. We're integrating their comprehensive reviews covering glomerular diseases, IgA nephropathy, rapidly progressive glomerulonephritis, nephrotic and nephritic syndromes, and proteinuria.
Yeah, and just a quick disclaimer before we get into all the mechanisms. This session is strictly for medical education and exam preparation. It is not medical advice. Any clinical decisions must always involve a qualified healthcare provider.
Totally. So to understand how the kidneys fail, you kind of have to understand how they filter in the first place, right?
Right.
And that starts with the glomerular filtration barrier. It's essentially, it's like a microscopic coffee filter made of 3 layers. You've got the fenestrated endothelium, the glomerular basement membrane, and the podocytes.
Yeah, those are the big 3.
And under normal circumstances, any protein leakage above 150 milligrams per 24 hours means that filter is compromised.
It does. And, you know, the filter actually relies on 2 distinct defense mechanisms to keep protein in the blood.
Oh, right, the size and charge.
Exactly. So the first is a physical size barrier, which is heavily dependent on a meshwork of type 4 collagen. It acts like a literal sieve, just blocking large molecules from getting through.
Okay.
But the second is the charge barrier. The entire capillary wall, and especially those podocytes, is coated in a negative charge.
And vital proteins like albumin are negatively charged too, right?
Exactly. It's like trying to force the negative ends of 2 magnets together. They just naturally repel each other.
That makes a lot of sense. So if the charge barrier breaks down, it's basically like losing the specific chemical coating on your coffee filter. I mean, the fluid still goes through, but that selective chemistry is totally ruined.
Right, you lose the selectivity.
But then if the size barrier breaks, it's like literally poking a physical hole in the paper. Everything just pours right through.
Yeah, exactly.
And the way we detect this leakage in the clinic, this is a massive area for MCCQE board traps. The standard urine dipstick is the universal first step, but it has a very specific, dangerous blind spot.
It really does. The chemical dye on a standard dipstick pad is primarily sensitive to electronegativity.
Meaning it's looking for the albumin.
Right. It's highly calibrated to detect albumin.
Yes.
But it will completely miss positively charged proteins.
And the classic board scenario for this, the one they love to test, is a patient with multiple myeloma.
Oh, absolutely.
They're leaking massive amounts of Bence-Jones proteins, which are positively charged immunoglobulins. So the standard dipstick will read negative.
Which gives you a totally false sense of security.
Exactly, while their kidneys are actively taking on severe damage. So to catch those, you specifically have to order a sulfosalicylic acid test, or SSA.
Right, the SSA test works through flocculation. You add the acid to the urine, and it just denatures any protein present regardless of its charge.
It just clumps it all together.
Yeah, it causes them to clump together and turn the urine cloudy. So if a patient have a negative dipstick, but a strongly positive SSA, you immediately start thinking about multiple myeloma.
That's such a high-yield takeaway. But let's look at the dipstick from the other side, though. Say a patient comes into the clinic, they've been running a fever, and they're, severely dehydrated.
Yeah.
If they give a highly concentrated urine sample, it seems like the lack of water could artificially concentrate whatever trace proteins are naturally there. Wouldn't that throw a false positive 3+ on the dipstick?
It absolutely can. That's why you always have to look at the urine-specific gravity alongside the protein reading. Like a 3+ protein in someone with incredibly dilute urine is a massive red flag. But that same 3+ reading in a severely dehydrated patient with highly concentrated urine well, that might just be an artifact of the dehydration. The dipstick only tells half the story.
Which means once we truly suspect proteinuria, we have to actually quantify it. And the gold standard is a 24-hour urine collection.
Yes.
But realistically, asking a patient to carry a jug around all day is just prone to errors and poor compliance. Nobody wants to do that.
No, nobody does. And that's why the spot urine protein to creatinine ratio, or UPCR, is so highly favored now.
You just need a single sample.
Exactly, ideally an early morning sample.
Yeah.
A UPCR greater than 15 milligrams per millimole warrants a serious workup.
Right, and for management, KDI Go guidelines strongly recommend starting adults on ACE inhibitors or ARBs if they have persistent proteinuria over 300 milligrams per 24 hours.
Then the mechanism there is crucial. It's because those medications dilate the efferent arteriole.
They basically open up the exit valve of the glomerulus.
Exactly. Which drops the pressure inside the filter and just gives those delicate layers a break.
That's a great way to visualize it. Now, once that filter is significantly damaged and the patient starts really hemorrhaging protein, the sheer volume and the type of leakage force the patient down one of two major syndromic pathways. You're looking at either nephrotic or nephritic syndrome.
Right. Let's start with nephrotic syndrome. This is the leaky state.
The really leaky state.
Yeah. The barrier is profoundly compromised, leading to massive non-inflammatory proteinuria.
And the cutoff number students need to memorize here is greater than 3.5 grams per day, right?
Yes, or a UPCR over 350 milligrams per millimole. And because the patient is dumping so much protein into their urine, their serum albumin drops below 30 grams per liter.
Which ruins the oncotic pressure.
Exactly. That loss of oncotic pressure causes fluid to just leak into the tissues, resulting in profound edema.
And the exam loves testing the underlying etiologies of this leaky state. Like minimal change disease is the most common in children.
Oh, very high yield.
Yeah, and under a standard light microscope, the kidney tissue looks completely normal. That's where the name minimal change comes from. But if you put it under an electron microscope, you see foot process effacement.
Right. The podocytes have literally lost their structural integrity.
They just flatten out, usually due to circulating cytokines.
Yeah.
But fortunately, it tends to have an excellent response to corticosteroids.
It does. Now, in adults, membranous nephropathy is a huge target. This involves autoantibodies actually attacking the podocytes.
Okay.
A major high-yield marker here is the PLA2R autoantibody, which targets the phospholipase A2 receptor on the podocyte surface.
Wow. Okay.
So this immune complex deposition happens right under the podocytes, and as the basement membrane tries to repair itself, like it tries to grow up and over these deposits, it creates a very distinct spike and dome appearance on electron microscopy.
Spike and dome, you have to know that phrase.
Absolutely.
Then you also have focal segmental glomerulosclerosis, or FSGS, which carries a much graver prognosis. It frequently progresses to end-stage renal disease.
Yeah, that one is tough.
And focal means only some glomeruli are affected, while segmental means only a portion of the individual glomerulus is actually scarred.
Right.
It's also heavily associated with ACOL1 gene variations, which explains why it disproportionately affects populations of African descent.
That's a critical demographic association for the boards. Now, when a patient is losing that much protein across any of these diseases, the systemic consequences are severe. But I find the resulting hyperlipidemia often confuses students.
It really does feel counterintuitive. Like, I completely understand why losing albumin causes the edema. The fluid just isn't being held in the blood vessels anymore.
Right.
But why does peeing out protein cause a massive spike in serum cholesterol and triglycerides? What's the link?
It basically comes down to the liver's panic response.
The liver panic.
Yeah, when the kidneys dump albumin, the blood's oncotic pressure just plummets. The liver senses this massive drop and goes into absolute overdrive to replace the lost proteins.
Oh, I see.
But the liver isn't a precision instrument here. It just ramps up production across the board, which includes mass-producing lipoproteins.
Yeah, okay.
And simultaneously, the enzymes that normally clear lipids from the blood-like lipoprotein lipase well, they're small enough that they're being lost in the urine too.
So it's a double hit.
Exactly. You have a factory overproducing lipids and a broken waste management system that is failing to clear them.
That paints a very clear picture. It's a compensatory mechanism gone totally wrong. And the complications of nephrotic syndrome don't stop at cholesterol, right?
No, they don't.
Patients are losing highly specific vital proteins in the urine. One of the highest yield exam concepts is the loss of antithrombin III.
Oh, they test this all the time.
Yeah, antithrombin III is a crucial endogenous anticoagulant. Without it, the patient's blood becomes incredibly hypercoagulable. You have to have a high index of suspicion for deep vein thrombosis or pulmonary emboli.
And they're also losing immunoglobulins, which renders them incredibly susceptible to severe infections.
Right, so if nephrotic is the pure leaky state, nephritic syndrome is the inflamed state.
Exactly.
The glomerulus isn't just a torn sieve anymore, it is actively on fire. And the hallmark here isn't massive proteinuria, though you do see, subnephrotic protein levels.
That's lower.
But the true hallmark is hematuria. It's often described by patients as cola-colored or tea-colored urine, and it's accompanied by hypertension and oliguria, meaning a severe drop in urine output.
And if you are looking at a urinalysis question on the exam, the absolute smoking gun for nephritic syndrome is the presence of dysmorphic red blood cells.
Specifically acanthocytes.
Yes, acanthocytes and red blood cell casts. Acanthocytes are red blood cells that have been just physically mangled, squished, and distorted as they were violently forced through the inflamed, swollen glomerular filter.
That sounds brutal.
It is at the microscopic level, and those red blood cell casts form when those mangled cells hit the renal tubules. The tubules naturally secrete a sticky substance called tam horsefall protein, or uromodulin.
Right, the gel.
Exactly. In a nephritic state, this protein acts like a gel, just trapping the red blood cells and molding them into the exact cylindrical shape of the tubule.
Oh, wow.
So if you see RBC casts under the microscope, it definitively proves the bleeding is originating high up in the glomerulus. It's not from a kidney stone or just a scratch lower down in the bladder.
That makes total sense. Now, zooming in on the nephritic side of things, we run into the most common cause of glomerulonephritis worldwide, and that's IgA nephropathy, or Berger disease.
It's definitely a big one.
For the MCCQE, you are practically guaranteed to see this disease pitted directly against its primary mimic, which is post-streptococcal glomerulonephritis, or PSGN. And telling them apart usually hinges entirely on a very specific clinical timeline.
It really does. But let's break down the pathophysiology of IgA nephropathy first. It basically relies on a 4-hit model.
Okay, 4 hits.
Right. Hit 1 is a genetic quirk where the patient produces an abnormal galactose-deficient version of IgA1.
Galactose deficient.
Yeah. Normally, IgA has this hinge region that's protected by galactose sugars.
Yeah.
But here, the sugars are missing, which leaves the hinge completely exposed.
Okay, so that's hit 1. Hit 2 occurs when an external trigger, commonly an upper respiratory infection, stimulates the immune system.
Right.
The body spots these abnormal, exposed IgA molecules and mistakes them for foreign invaders, so it generates IgG autoantibodies against them.
Exactly. Then hit 3 is the formation of circulating immune complexes, as those IgG antibodies just lock onto the abnormal IgA.
And then they get stuck.
Yes. The final hit, hit 4, is when those bulky complexes get physically wedged into the mesangium of the glomerulus. The immune system tries to clear them out, which triggers a massive complement activation and severe localized inflammation.
And clinically, this presents as synpharyngetic macroscopic hematuria. Synpharyngetic is the operative word there.
It's the key word.
It means the visible blood in the urine happened concurrently with or within just a couple of days of the upper respiratory infection. They happen at the same time.
And from a treatment standpoint, conservative management with ACE inhibitors or ARBs is standard just to manage the blood pressure and the proteinuria. But there are some fascinating novel agents you should be aware of.
Oh, right, like the targeted steroids.
Yes, targeted release budesonide, known as Nefecon. It's specifically designed to release its steroids at the Peyer's patches in the gut mucosa.
Why the gut, though?
Because the gut is where a massive proportion of this galactose-deficient IgA is actually produced. So it essentially attacks the problem at the source. There's also sparsentan, which acts as a dual endothelin and angiotensin receptor antagonist.
That's really interesting. It's also notable that in certain Asian populations, particularly in Japan, tonsillectomy is a frequently utilized intervention.
Oh, yeah.
By removing that specific mucosal lymphoid tissue, they aim to significantly decrease the overall production of the pathogenic IgA.
It's a very targeted approach.
Yeah. Now, contrast all of this with post-streptococcal glomerulonephritis. PSGN typically erupts 2 to 3 weeks after a strep throat infection or a skin infection like impetigo.
And that timeline is the crucial differentiator. Under immunofluorescence on a biopsy, PSGN looks entirely different from IgA. You see a starry sky or a lumpy, bumpy pattern.
Lumpy, bumpy.
Yeah, this is because the immune complexes, mostly IgG and C3 here, they deposit in random, scattered clumps just under the epithelial layer. When tagged with a fluorescent dye, those scattered clumps light up against the dark background, literally like a starry night sky.
And thankfully, especially in children, PSGN is usually acute and self-limiting with just supportive care.
Yes, usually.
I always think of the timeline distinction using a fire alarm analogy.
Oh, I like analogies, so let's hear it.
So IgA nephropathy is like the fire alarm going off while the house is actively on fire. The respiratory infection and the hematuria are happening at the exact same time.
Right, synpharingitic.
Exactly. But PSGN is like a faulty smoke detector that suddenly decides to go off 3 weeks after the fire department has completely extinguished the blaze and driven away. The initial strep infection is long gone, but the delayed immune complexes are just now wrecking the kidneys.
That is a perfect way to remember it for the exam. But, while IgA and PSGN often have manageable trajectories, we have to address what happens when glomerular inflammation doesn't self-limit,
When it spirals.
when it spirals into a complete system collapse. And that brings us to rapidly progressive glomerulonephritis, or RPGN.
Yeah, our PGN doesn't give you years. By definition, it is a rapid, catastrophic decline in renal function occurring over just weeks to months.
It is incredibly fast.
And the defining histological feature is the presence of crescents in Bowman's space. Bowman's capsule is the cup that holds the glomerulus. When severe inflammation causes fibrin to leak into that space, it triggers the parietal epithelial cells and macrophages, lining the cup to just proliferate wildly.
They form a literal cellular crescent moon shape.
Right, and it physically crushes the fragile glomerular tuft inside.
And if you don't intervene immediately, those cellular crescents undergo irreversible fibrosis. They turn into the permanent scar tissue, destroying the nephrons completely and sending the patient straight into end-stage renal disease.
It's terrifying.
It is. For the exam, you have to be able to categorize RPGN into 3 distinct types based on what the immunofluorescence biopsy shows you.
Okay, so type 1 is anti-GBM disease. This is characterized by a smooth, linear staining pattern. The body is generating autoantibodies that directly attack the alpha-3 chain of type IV collagen native to the basement membrane.
Right, it's a direct attack.
And the fluorescent dye paints a solid line right along the membrane. Now, if those same antibodies travel up and attack the identical collagen in the alveolar basement membrane of the lungs, causing pulmonary hemorrhage, it's officially classified as Goodpasture syndrome.
Exactly. Then you have type 2, which is immune complex RPGN. This shows a granular staining pattern. It's somewhat similar to the starry sky we talked about in PSGN, but far more aggressive.
Okay.
And this isn't a unique disease on its own. It's basically what happens when conditions like severe IgA nephropathy, lupus nephritis, or severe post-infectious glomerulonephritis push the glomerulus way past the point of no return.
They just tip over into RPGN. And type 3 is pouchy immune RPGN. Pouchy meaning few or scarce. If you look at the immunofluorescence, it's essentially blank. There are little to no glowing immune deposits.
Which is so weird to think about.
Right, because instead the destruction is being driven by circulating anti-neutrophil cytoplasmic antibodies, or ANCAs, in the bloodstream. Specifically, you're looking for PR3 ANCA, which is heavily linked to granulomatosis with polyangiitis, or MPO ANCA linked to microscopic polyangiitis.
And, the StatPearls text actually highlights a very specific clinical scenario regarding these antibodies that makes for a perfect exam trap. It discusses double positive patients.
Right. So a patient's serology comes back testing positive for both anti-GBM antibodies and ANCA antibodies.
Yes.
So if they have the markers for both type 1 and type 3, how does the disease actually manifest clinically? Like, which pattern wins out?
It's fascinating. The kidneys follow the anti-GBM pattern. They suffer highly aggressive crescent formation and a rapid plunge into renal failure. However, their extrarenal systemic symptoms, like vasculitic skin rashes or nodules in the upper respiratory tract, those mimic ANCA vasculitis.
So they get the worst of both worlds.
Pretty much. The prevailing theory is that the systemic ANCA vasculitis strikes first, damaging the glomerular basement membrane. That initial damage exposes hidden collagen epitopes that the immune system normally never even sees.
Oh, wow.
Which in turn triggers the body to synthesize the anti-GBM antibodies as a secondary, basically fatal blow.
That is a brutal cascade. And because RPGN is so fiercely aggressive, the management protocols emphasize speed above literally all else.
You cannot wait.
If your clinical suspicion is high, say you have a patient with rapidly declining kidney function, hematuria, and maybe pulmonary symptoms, you do not wait for a definitive biopsy to return before acting.
No, you treat empirically.
Right. With pulse B-methylprednisolone, a heavy immunosuppressant like cyclophosphamide or rituximab, and critically, plasmapheresis.
Yes. Plasmapheresis or plasma exchange is especially vital in anti-GBM disease, or if there is active pulmonary hemorrhage. You are physically pumping the patient's blood through a machine to filter out and remove those destructive autoantibodies before they can trigger more crescents. Time is quite literally nephrons.
Time is nephrons. I like that. Well, we've mapped out a massive amount of pathology today. Let's run a rapid-fire recap of the highest yield MCCQE takeaways.
Sounds good.
First, the dipstick trap. Standard dipsticks rely on negative charge and will completely miss Bence-Jones proteins. You must order an SSA test for suspected multiple myeloma.
Second, in nephrotic syndrome, remember the profound hypercoagulability. Patients are actively peeing out their antithrombin III, placing them at incredibly high risk for deep vein thrombosis and pulmonary emboli.
Third, memorize the nephritic timeline trap. IgA nephropathy presents with synpharyngitic hematuria happening concurrently with the respiratory infection, but PSGN has a delayed onset, striking 2 to 3 weeks after the infection has cleared.
And finally, the presence of crescents in Bowman space definitively points to RPGN, which is an absolute medical emergency requiring immediate aggressive immunosuppression to prevent permanent fibrosis.
Mastering these concepts goes far beyond just passing the MCCQE.
Yeah.
Recognizing these patterns in a real clinic or emergency room is what allows you to differentiate between benign, transient proteinuria and the early warning signs of RPGN.
It all comes down to preserving that microscopic filtration barrier. It is incredibly delicate, and when its intricate balance of size and charge is destroyed, the systemic consequences cascade through the entire body.
To leave you with a final thought to mull over, consider the raw clinical dilemma of treating RPGN. Go back to that patient we imagined at the start, sitting in the ER, coughing up blood, their creatinine spiking daily. The serology and biopsy results won't be back for days. You have to weigh the severe, potentially fatal immunosuppressive and hemorrhagic risks of initiating empirical cyclophosphamide and plasmapheresis right now against the grim reality that with every single passing hour, irreversible fibrotic crescents are forming and permanently strangling their kidneys.
It remains one of the toughest calls in medicine, relying entirely on your clinical judgment and a deep mechanistic mastery of these very concepts.
Thank you so much for joining us on this deep dive. We hope this review has taken the highly complex world of glomerular diseases and made it a lot more intuitive for you. Best of luck on your exam prep, keep studying hard, and we will catch you on the next one.